Looks great.
Okay. Yeah, no, appreciate the opportunity. Always happy to be involved with fellow education, and I have the added benefit of getting a little pause during a busy call weekend to hear some great talks. So, I think we have some really nice talks on the algorithm. How to strategize, how to optimize. My goal actually is to sort of hopefully try to tie that all together, specifically related to cases that involve calcium and in-stent restenosis. And before I go forward, I'll just make another comment, and panelists can chime in and share their thoughts here. But I like to say that OCT represents, really, during my time as an interventional cardiologist, the first introduction of AI into interventional cardiology. And that, coupled with the power of the OCT software, a workflow algorithm like the MLD Max algorithm, is really a paradigm shift from intracoronary imaging being an adjunct to angiography to angiography being an adjunct to intracoronary imaging, because you get all the information for your stent size and your stent length and how you're going to treat the vessel. So I think it's a really exciting time, and I think we're going to get a tremendous amount of information out of projects like Illumian 4 and the Light Lab. These are my disclosures. We've seen a lot of these slides. I'm going to go quickly through the background and some of my background slides, try to get to the cases to illustrate the MLD Max algorithm, sort of from beginning to end on several cases. But calcified lesions and in-stent restenosis, remain some of the most difficult lesion subsets that we treat. They're obviously associated with increased rates of procedural complications. They're the cases that give us the most headaches in the cath lab and cause the most frustration. I think both are frequently underestimated by angiography. Calcification is frequently obviously underestimated. Severity of lesions related to in-stent restenosis is underestimated. And they frequently require lesion prep to facilitate procedural success, and intracoronary imaging, obviously, has been stated, can be really helpful for that. So when you talk about, calcified lesions and in-stent restenosis, I mean, there's no quote that rings truer than this one from Benjamin Franklin, that by failing to prepare, you're preparing to fail. And so the value of intracoronary imaging is just that. It's allowing you to prepare the lesion and get the best possible result. So we're going to go through some case examples for treating calcification and in-stent restenosis lesions. I'm going to try and highlight the role and benefit of intracoronary imaging, specifically with OCT, the impact of OCT on lesion prep and procedural success. And then we're going to go through the modern OCT guided workflow, the MLD Max algorithm, really from beginning to end here, and sort of try to illustrate what's already been very, very nicely explained. So this is a slide that I think, most of us have seen from Dr. Richard Schlafmitz before. The calcium problem, underestimation of calcium can lead to issues down the line. So in the absence of intravascular imaging, there's almost always an underestimation of calcium. That increases the likelihood of improper vessel prep and stent underexpansion, increased risk of complications, and then just from a practical purpose, headaches and longer procedures and more stents. And Evan went through this nicely. I'm not going to spend a lot of time on this, but just understanding what calcium looks like by OCT. It's got very distinct appearance. I always tell people I spend most of my time when looking at morphology trying to assess for calcium, because it's going to have the greatest impact on what I'm going to do during an intervention. But that's the distinct appearance of calcium: clear borders, low attenuation. And it's not only important to identify calcium, but to identify where calcium is. If it's deep in the vessel wall, traditional techniques such as cutting balloon or NC balloon or scoring balloon, or maybe down the road intravascular lithoplasty are appropriate. If it's nodular or superficial, you really want to use an ablative technique like atherectomy, or again, potentially intravascular lithoplasty down the road. I think everybody here is obviously an advocate for intracoronary imaging, and that's IVUS and OCT. I think every lab should have both IVUS and OCT. Every operator should be proficient in both IVUS and OCT. We have to understand the benefits and the shortcomings of both modalities. And clearly, when it comes to calcium, OCT really shines. There's a tremendous amount of advantage. This is just a very nice illustration of that. You see calcium that's deep and thick by OCT, and then you see over here on the left side, and then you see calcium that's superficial by OCT. That same vessel is imaged by intravascular ultrasound. You really can't appreciate that depth of calcium because of the dropout behind it, and so it doesn't really allow you to make as good of a decision for vessel prep as compared to OCT, and that's really one of the strengths. Evan went through this nice. I'm not going to spend a lot of time on that, but this is the calcium volume index score, which put out by the CRF group, and led to the rule of fives that we're going to talk about a little bit as we go through the cases. So just real quick again, the rule of fives: a 0.5 millimeter thickness, 5 millimeters of length of calcium, and a 50% vessel arc. Those are really going to be the parameters that are going to cause you to change your strategy with regard to treating calcium, because we know that extensive calcium, the presence of calcium, and a high calcium volume index score is going to result in inadequate stent expansion more frequently. And then quickly to talk about just some background on in-stent restenosis. I think it's pretty well accepted that if you have stent failure, whether that's stent thrombosis or in-stent restenosis, intracorneal imaging really should be mandatory. And when it comes to in-stent restenosis, it will really help you guide therapy, just like we've talked about with regard to most of our PCIs. So if you have neointimal hyperplasia, it can allow you to define it further, whether it's calcific, fibrotic, or lipidic, and pick an appropriate treatment modality. And then very importantly, is the in-stent restenosis really stent under expansion? And that's going to be a very, very different approach with the use of high pressure balloons, maybe laser atherectomy, maybe intravascular lipoplasty, or even rotational atherectomy in some instances. So getting on to our first case, this is a 65-year-old Hispanic male. He has a history of hypertension, dyslipidemia, COPD, presented with new onset angina. He unfortunately continued to smoke. His echocardiogram revealed borderline LV function. He had an ischemic nuke that led to a diagnostic cardiac catheterization that revealed a CTO of the RCA and obstructive disease in the LAD and the major diagonal branch. So he had a hard team approach, talking about options, and it was decided that we proceed with PCI for him. Here's his guide shot for his planned intervention, and you can see that he's got extensive LAD disease in the proximal mid-segment of the vessel and involving the major diagonal branch. Angiographically, I felt that there was some degree of calcification, but it didn't appear to me that he needed atherectomy right up front. This is a lesion where advancing an OCT catheter without prepping the vessel to some degree would be problematic. You won't get clearance to blood, and the catheter is likely to be occlusive, so it'll impair your image quality. So I did low pressure balloon inflation here, and then proceeded with my pre-PCI OCT to strategize. And so here's the co-registration run. Again, MLD max. We're going to start first with morphology. I'm going to let this play through here. What you see here is that there's sort of mixed plaque. There's fibrotic plaque, and there's some areas of calcification that you see, but there's not really extensive calcification throughout the disease segment. And certainly, as you think about the calcium volume index score, it didn't occur to me that the number was very high and that he needed any further aggressive vessel modification. Here's a couple of spots of interest. You see some nodular or some calcium thickness there in that segment. A little bit of arc of calcium here in the proximal and the mid vessel, but nothing circumferential, nothing of significant length or thickness that I felt required us to do anything different. Moving on to the length segment, so we're in the L and MLD max. And what you want to do here, as illustrated nicely by Taj there, is that scroll through your disease segment, identify your proximal and distal healthy landing zones and reference vessel segments. So this right here is the distal landing zone. I felt that was a nice healthy area to land a stent distally. This is the proximal landing zone. Maybe not quite as healthy, but was the best segment that I could find. And then you'll notice that the length there is 38 millimeters. And so I wasn't lucky in getting to 38 millimeters. I had to make some adjustment with the proximal or distal edge, as we saw in the previous presentation, and matched it up to a commercially available stent length of 38 millimeters. I then go on to diameter here and the MLD max, and again, you just go to those same segments. And in this run, I was able to identify the EEL fairly easily for the distal reference segment, and we measured it at 2.9. proximally as well with a little bit more difficulty, but I felt the EEL was able to be measured and measured it at 3.6. And so now I have all the information that I need to proceed with PCI. So again, using the algorithm that we talked about for stent sizing, I know that I've got some degree of calcification, but I don't need any further extensive plaque modification. I have a lesion length of 38. I've got a distal reference vessel size of 2.9, so I'm going to round down to the nearest available stent size. And so what I need is a 2.75 by 38 Zion stent here in this case, and I'm going to post-dilate it with a 2.75 non-compliant balloon distally and a 3.5 non-compliant balloon proximally, rounding down based on those EEL measurements. I did choose to treat this a little bit further with a cutting balloon prior to advancing the stent. There's the 275 38 millimeter stent. Here's a post-dilation balloon with an NC Emerge 275 15 and a 35 12 proximally. And one of the nice things about this is that you're not taking a lot of images and angiograms to make decisions between each inflation and after the stent placement. You're pretty much just trying to make sure that you haven't had any vessel injury, and then you're ready for your post-PCI optimization run. So here's the post-PCI optimization run. Moving on to the second portion of the MLD Max algorithm, we get to the M segment. We're looking for medial dissection. The software here obviously very powerful. You have the rendered stent image up on the post-PCI OCT run. You can quickly scroll to the distal edge. You can see a few stent struts here. So you know you're at the distal edge of the stent. There's no evidence of dissection. Go proximally. You can see some stent struts here, and no evidence of that was distally, and no evidence of dissection here proximally. Moving on to apposition, looking basically to see if the stent is well opposed to the vessel wall. And as you run through the run here, you can see that you've got good stent apposition throughout the distal and mid and the majority of the proximal third of the stent. And then when you get to the very proximal segment of the stent, you see you have significant malapposition. And to the point that was made earlier, stent malapposition, while I think people get very excited about it, intuitively just feels, wrong and worrisome, it's not typically associated with adverse events. Now, having said that, this degree of malapposition proximally is something that I would treat every time, because not doing so, I think, would complicate further attempts at intervention or any future procedures. And the other point here is, the power of this software, that you have a stent apposition indicator. You've got a rendered stent that will change colors based on the presence of malapposition. So very quickly, looking at this image right here, you know that you have stent malapposition in this segment, and you can go and look and confirm that that's accurate. And sure enough, here you see that there's malapposition proximally. And then finally, expansion. You have the most important parameter post-PCI gets us to the X portion of MLD Max. So this is expansion. This is going to be the tapered mode that was just shown. And what you see here is that you have a segment of stent under expansion distally. It's the software calculates that at 76%. You can see that the distal reference segment, as shown there, is 4.7 millimeters squared. The area of stent under expansion, as identified by the software, is 3.59. That gives you the 76% under expansion measurement. And just as was mentioned, after placing the stent and performing the PCI, you can get some vasodilation of the vessel. So if you follow the algorithm and you still have under expansion, it's worthwhile to make another measurement. And if you go to the distal segment, you make another measurement, EEL to EEL, you see that it now measures 3.1 millimeters. So you round down to the nearest available balloon, and now you're doing a post-dilation distally with a 3 millimeter non-compliant balloon, as opposed to the 275 previously. I had the 3.5 on the table, so went ahead and treated the proximal malapposition, and then you have a final angiographic result that you can be confident in. We'll move on to another case here. Anybody can feel free to interject at any point, but this is a 79-year-old female with a history of coronary disease, previous cardiac catheterization a couple years prior, had intermediate mid-LAD disease at that time, was treated medically, but had progression of symptoms over the last 2 years, prompting repeat cardiac catheterization that I'm about to show you here. She also had atrial fibrillation, and she was a diabetic. This is their diagnostic angiogram, and you can see that she's got, functionally chronic total occlusion of the proximal to mid-segment of the LAD. You can tell angiographically that there's extensive calcification, TIMI2 flow distally, and certainly the culprit of her progressive symptoms. So we proceeded with intervention here using dual injection. The lesion was crossed with wire escalation strategy with a Turnpike LP and a Fielder XT. And I decided here to go ahead and right up front proceed with rotational atherectomy with 1.5 millimeter burr. Dilated the vessel with a 2.5 millimeter balloon, and then prepared for my pre-PCI OCT run to strategize again. And then just as before, we start with a morphology assessment of the first M and the MLD max. And you can see here right off the bat, it's a much longer lesion. Again, you have some mixed plaque morphology in the distal disease segment. But as you move through, you're going to see a lot more extensive calcification through the proximal and mid segments of the vessel. And so now, as compared to the last case, you see extensive calcification, circumferential calcification. You see significant thickness of the calcium. And now that we're post-atherectomy, you can appreciate some calcium fracture. So you know that you've modified the plaque to an adequate degree. And you also see some vessel dissection where certainly it was ballooned and pre-treated. The length calculation here a little bit more difficult because the lesion is very long. So you have a long lesion. You have to identify the distal reference vessel or landing zone and the proximal landing zone that seemed the most suitable. You can see here that when doing that, you get a length of 56 millimeters. So you know you're going to need a 2-stent strategy. And measuring the diameter, you can see distally you have an EEL that the pointer there is incorrect. That's the distal reference segment, and based on EEL measured 2.6 millimeters. And this is a good example of PCI where distally we're going to size based on EEL, but proximally size based on lumen because I couldn't identify the EEL. And so proximally we measured a lumen size of 2.28. And again, based on the information that you have here, you know that distally you're 2.6. You're going to round down to a 2.5 millimeter stent. If you decide to use a 38 millimeter stent, you're going to need the additional length to cover 56 millimeters with minimal overlap as you can achieve. And then proximally, if you're going to treat that vessel based on what the likely size is, you're going to end up dealing with a vessel that's about a 0.5 millimeter bigger than a 2.28 lumen size, so it's likely to be about 2.75. So distally, you got a 2.538, proximally a 2.7523, post-dilated distally with a 2.515 balloon, and proximally with a 2.7530 balloon, and then proceeded with a final OCT run after to optimize. And you can see the angiographic result is good. And here, again, we'll look for medial dissection, go quickly to the distal and the proximal edges of the stent based on the rendered stent. You can see there's some swirl here distally, but no evidence of vessel dissection. The proximal stent comes right up to the takeoff of the circumflex artery. Moving on to apposition, throughout the stented segment, you have excellent apposition. You see that your stent apposition indicator is highlighted here through the mid-segment, but you really have not significant malapposition in the mid-segment of the vessel. And I didn't feel that required any further treatment. And then finally, expansion. I'm going to show you both modes here. You have both the tapered mode as well as the dual reference mode, and both confirm excellent expansion, 96% based on the tapered mode. And again, looking at the dual reference mode, both calculated based on the proximal and distal reference segments, you've got 96 and 97% expansion, so I was pleased with that. I think you have time for one other case. Yes, Dr. Waxman?
That's Kevin, actually. I just wanted to point out one thing. That case you showed a few minutes ago was beautiful. We didn't harp on enough the power of the co-registration. I mean, you know exactly where the OCT image is coming from on the angiogram. So for a long diffuse lesion case like that, it's pretty cool because effectively the OCT allows you to paint by numbers. You know exactly where you're landing the stent. There's no more counting side branches and trying to guess. And so that part of the workflow is really helpful in terms of knowing exactly where you're landing things based on the angio.
Yeah, no, totally agree. The co-registration is a really key and helpful component to this, and I think a real advantage. I'm going to move on to the next case if we have time. If I need to stop, just let me.
Go ahead.
Okay. So the final case is a 74-year-old male with a history of coronary disease, hypertension, and hyperlipidemia. He's also diabetic. He underwent PCI of the LAD 15 months prior, and review of that procedure report indicated that he underwent PTA and stent placement. Importantly, there was no imaging or vessel prep documented. He additionally had a history of diabetes, sleep apnea, and hyperlipidemia. So this was his angiogram after presenting with escalating symptoms. And you can see heavily calcified vessel. He's got multiple previously placed stents. He's got tandem lesions in the proximal mid-LAD, one of which appears to be a calcified lesion proximally, followed by an area of severe in-stent restenosis. So this is his pre-PCI OCT to strategize, and again, looking at morphology. What you see here is just the OCT software is picking up the rendered stent from the previous PCI. Here in the distal segment of the mid to distal segment of the vessel, you see that there's some mild neotomal hyperplasia, but nothing significant. And then as you come into this segment right here, you see that there's severe circumferential calcium that's resulted in severe stent underexpansion. And so this is a really good example of in-stent restenosis secondary to stent underexpansion that occurred because the stent was implanted in a heavily calcified lesion that had no vessel prep prior. And Joe, just to remind you, we'll have another slide I'll show you in a second, but the length in this situation is a little bit different based on what we saw before because it's all in stent. So we're really just looking at the area or the segment that we need to treat within the ISR segment. In this case, we calculated this out to be at 34 millimeters. There's the reference segment of the vessel, and a lesion length of 34 millimeters. And then finally, diameter. Distally, we measured the lumen at 379, proximally at 398. And that allowed us to pick a balloon size, initially trying to dilate the area of underexpansion with a 3.5 by 8 NC emerge to 22 atmospheres, followed by 3.5 by 15 balloon to 24 atmospheres for a prolonged period of time, followed by 3.75 by 15 millimeter balloon to 24 atmospheres for a prolonged period of time, followed by a 4.0 by 15 millimeter balloon to 24 atmospheres for 90 seconds. And you can see that despite aggressive balloon dilation with increasing balloon size, there remains a waste in the balloon and significant stent underexpansion. And so I think this is a great cautionary tale for the fellows, primarily that the best way to not have to deal with this situation is to avoid getting into it in the first place, and not placing a stent in a vessel, in a lesion that's not dilatable. And then just again to remind you about in-stent restenosis secondary to underexpansion. The mechanism is underexpansion, and so the treatment will be different than if it was neotomal hyperplasia. So this person came back for a stage intervention. We elected to proceed with intravascular lithoplasty with a 40 millimeter balloon. Underwent multiple pulses for a total of 160 pulses. We could actually see expansion of the stent with the delivery of the pulsation. And angiographically, you could see right away that there was improvement of the lesion. Here's a follow-up OCT run after the intravascular lithoplasty. You can see that the MSA has already increased to 4.89 millimeters squared. And you can see segments of the vessel where there appears to be calcium fracture related to intravascular lithoplasty. So that along with the increase in the MSA was very reassuring. Went ahead and dilated that lesion aggressively with a 4 millimeter balloon, and then moved on to our post-PCI OCT run to optimize. And so looking first for medial dissection, again, distally we're all within a stented segment, so not as much of a concern. But in that proximal vessel, just proximal to the previously placed stent, you can see that we did end up having significant medial dissection, and I think, meeting criteria for treatment. looking at apposition. Again, not as much of a concern because we had a stent previously placed that was opposed. But then looking at expansion, importantly, we can see that we've now achieved an MSA of 7.65 with an expansion at 82%, which certainly would meet the criteria for acceptable. We've followed with stent placement to the proximal segment of the LAD to treat the dissection, and this was our final angiographic result here. So in conclusion, severely calcified lesions and in-stent restenosis can present significant challenges during coronary PCI. Intracoronary imaging is valuable and, I would say essentially a mandatory tool to guide treatment in these cases. Lesion preparation, understanding the tools available for treatment are key for procedural success, and a modern OCT-guided PCI workflow, as I mentioned to start, can help both strategize and optimize the procedure. I think represents, a paradigm shift in potentially how we perform PCI. So thank you.